Good morning, everyone. My name is Iris Levine, and I'm a pre-med student working with the research group at University Hospitals. I'm excited to present my research on the implications of sac excision on hernia recurrence and postoperative GERD in paraesophageal hernia repair. And here are our disclosures. Let's start with a brief overview of paraesophageal hernias. Surgical intervention is often necessary to repair paraesophageal hernias and prevent complications. One crucial aspect of hernia repair surgery is the management of the hernia sac. Hernia sac reduction is a vital part of successful paraesophageal hernia repair. Sac excision has also been proposed as an integral part of successful repair in treating paraesophageal hernias. The objective of this study was to assess the implications of sac excision on hernia recurrence, reoperation rates, and postoperative GERD in patients undergoing hernia repair surgery. To achieve this objective, we conducted a retrospective analysis of patients who underwent paraesophageal hernia repair at a single institution between 2014 and 2022. We collected and analyzed data on patient demographics, preoperative evaluation, surgical technique, specifics of sac excision, and long-term follow-up data. Now let's take a closer look at the demographics of the patients included in our study. Patients who underwent sac excision were older, had higher rates of smoking, higher rates of cardiovascular disease, and a slightly higher ASA class. Now let's examine the key findings from our study. We found that sac excision did not significantly impact hernia recurrence. 14.8% of patients with sac excision had recurrence, while 17.5% without sac excision had recurrence. This suggests that the presence or absence of sac excision during hernia repair surgery did not affect the likelihood of hernia recurrence in our patient cohort. Similarly, sac excision was not associated with a lower rate of reoperation. 7.3% of patients with sac excision had recurrence, while 5.7% without excision had recurrence. This indicates that the decision to perform sac excision during hernia repair surgery did not influence the need for subsequent reoperations in our study population. However, we did observe a significant association between sac excision and a lower incidence of persistent postoperative GERD. 4.6% of patients with sac excision had GERD more than 30 days postoperative, while 8.3% of patients with no sac excision had GERD. This suggests that patients who underwent sac excision during hernia repair surgery were less likely to experience persistent GERD symptoms following the procedure. Furthermore, we completed a subset analysis comparing patients who underwent a fundoplication both with and without sac excision, and the result was similar with higher rates of GERD in the fundoplication with sac excision group. 4% of patients with fundoplication and sac excision developed persistent postoperative GERD, whereas 9% of patients with fundoplication and without sac excision developed postoperative GERD. These findings highlight the potential role of sac excision in mitigating postoperative GERD and suggest its importance in the context of hernia repair surgery, even in combination with fundoplication procedures. These findings suggest that while sac excision may not affect hernia recurrence or the need for reoperation, it may play a protective role against persistent postoperative GERD. Moving forward, further research is needed to optimize surgical techniques and minimize reoperation rates. Additionally, exploring the mechanisms underlying the protective role of sac excision against postoperative GERD could provide valuable insights for improving patient outcomes. Thank you.